Every year, just under 1 million Americans suffer from strokes. And it wasn't too long ago that doctors didn't even really treat stroke. They didn't have a way to. But today, doctors have a new tool in their toolbox. Andrew Southerland is a physician and professor of neurology at the University of Virginia. And he's been working with a technique to remove stroke-causing blood clots that's just recently been recommended by the American Heart Association. Andrew, clinical trials recently confirmed in resounding fashion that a surgical treatment for certain types of strokes is enormously beneficial. Did you and your colleagues see it as a game changer?
We really did. It is a paradigm shift in the treatment of acute stroke for me and my colleagues, but for stroke patients and treating stroke physicians throughout the country and the world, really.
What did the studies say?
They suggest that certain stroke patients that are having more severe strokes that are eligible to get a clot retrieving type of treatment. And this is basically similar to getting a catheterization for your heart, which people know about. Instead, we go up into the brain and we can remove the obstruction that's causing a stroke.
So in the past, our stroke treatment for people, even with devastating strokes, was to give them what they call clot buster medication?
Exactly. This was sort of a wide net approach where you give a medicine in the vein and it sort of essentially goes throughout the circulation and tries to break up blood clots that are obstructing blood flow to the brain. In this case, we actually go to the clot itself and try to pull it out. So it's two different types of plumbing, so to speak.
But haven't we known how to pull it out from the brain for a long time?
We've had devices that can do that. The problem is we haven't been able to show until recently that those devices can actually work in a timely enough way to make a difference.
Have you ever used such a device?
Me and my colleagues have. We have a sort of a team approach on the acute end. I'm the clinical guy that comes in and handles and diagnoses the stroke, and then I work with my neurosurgeons and neuroradiologists who then do the technical work.
So there were some times when doctors in America and even on your team were using these devices to extract the clot physically from the brain.
Exactly, and that's indeed what we've been trying to research and learn about over these many years and have really hit the jackpot now with 5 different clinical trials on multiple continents all showing the same thing.
So in the past, let's say your team, how did you know when to extract the clot physically and when to only use medicine?
Well, partly it has to do with how severe the patient's stroke is, and that's where my job comes in to sort of diagnose it and sort of know where in the brain the abnormality is going on. But we also have to be able to do some advanced imaging to be able to see that and see exactly where that clot is. Because if we don't see the clot, then it's hard for us to justify going up there and putting the patient at risk to try to do that sort of treatment.
So imaging to see the clot has vastly improved only very recently.
It's gotten better and better over time, and these are specialized CAT scans where we can give dye in the blood and we can actually go up and see a roadmap of the circulation. We can really see a very intricate map of the brain and know exactly where these obstructions are going on that we can treat.
Here's the thing that makes everybody crazy. Apparently, there were 3 studies just in 2013 that indicated the opposite of what we're now being told. They said surgery was not more effective than the drug alone. So how could there have suddenly been this turnaround?
Yeah, I think that's interesting, and frankly, it's confusing. We sort of re-upped on those negative trials a few years back. And the difference is we selected the right people that were going to benefit, and that was key. Rather than trying to treat everyone, we selected the people that were going to benefit, and they benefited a lot. And I should also say we had better devices. There's been a lot of evolution in the technology. We're getting smarter, and some of the earlier devices just didn't work that well.
Isn't that fascinating? So 2 years ago, rather than just drop it, 3 things changed. We did a better job of selecting the patients. We had better technology to see the clots that you could work on, and we had better trained doctors. What kind of device change was there? A tinier catheter?
Not tiny. It's sort of the type of device. The earlier devices sort of work like a corkscrew. These newer devices really work like a cage, and they trap the clot in essentially chicken wire, but do a lot better job of getting the clot out, and they're easier to manipulate up through small tortuous arteries.
Let's say I'm in my car and I realize something's terribly wrong, and then it dawns on me, oh my God, I may be having a stroke. How will the emergency responders know whether I'm one of those candidates for the clot remover versus the clot buster?
There's a couple parts to that. One, you need to know the signs and symptoms of stroke and know what they look like in other people and call 911. and get emergency responders there immediately. For our emergency response teams, they have to work closely with their community hospitals to be able to know who offers what types of treatment and what's the best triage plan for individual patients.
In other words, the time window is narrow, and it could make a big difference whether they're treated at a local hospital or a primary care center.
Absolutely, and it really all centered on this motto of time is brain. The sooner we can get to a patient, the more impact we can have because we have this new treatment.
I've never heard that. Time is brain.
It should be on everyone's bumper sticker. It is really our marching credo, and from the moment that a stroke starts, no matter what kind of stroke it is, to the moment that we can potentially get them into one of these treatment pathways, we can make a difference for the rest of their life. So minutes account for years and years, and that's so powerful.
And what do the studies show can be the difference for that patient to actually have the clot removal versus the drug?
It's huge in the score of 30 to 40% reduction in lifelong disability. Really, the difference between walking out of the hospital and going on to enjoy a quality of life versus, unfortunately, rolling out of the hospital or going to a facility or a place where you're going to be dependent on nursing care.
Of all the strokes that there are in the United States every year, it's under 1 million, but not far under.
No, not at all. We have about 800,000 new strokes each year in the United States, and that number's only going to grow.
In layman's terms, the kinds that would be treatable versus not would typically be where the arteries are large enough to get the tools in there?
You bet. I mean, how big is the pipe where there's an obstruction that you can essentially get the coat hanger in there and remove the obstruction? That simplifies it, but that's it.
Have you seen any evidence where you're getting better outcomes with a certain percentage of your patients now that you're doing both therapies?
It's at the individual level, it's all going to be anecdotal, but the anecdotes are great. We treated a gentleman the other day from a neighboring county who is retired. He enjoys working around his house. He's a big ham radio guy. Does a lot what we're doing right now. And he came in, with a huge severe stroke. He couldn't talk, couldn't use his right side of his body. If he had been left that way, he had been disabled for the rest of his life. And he was able to get the initial treatment, the clot-busting medicine, at his community hospital, and they rightly identified him. We actually did something called telestroke, which I'll tell you about in a minute, where we could actually see him at the community hospital, brought him here, went in, removed the clot, and he walked out of the hospital. And I just saw him in clinic the other day, and he's doing great. And that's the kind of stuff that motivates us with this treatment and this research.
Oh, that's amazing. How did you realize he might be a guy who would benefit?
Yeah, so I mentioned the telestroke piece. What telestroke is it's using video conferencing, telemedicine, so that me, the stroke doctor, can actually video in and evaluate the patient anywhere really, but in our area in a neighboring hospital that may not have a neurologist on call 24/7. And I can do an exam and identify, sort of pluck out the ones that I think are going to benefit from different types of treatment.
When you saw him remotely via telemedicine, what determined for you, we should bring this guy in?
So one, how severe his stroke was. When I saw that he couldn't speak, couldn't produce any words, and I think people know this as aphasia, the inability to speak, and you've seen stroke patients that have that, and he couldn't use his right side. That automatically tells me he's having a big enough stroke that this is likely being caused by a big blood clot in a big artery. So that gives me a clue that he's going to be one that might benefit from this additional treatment.
What do a lot of people get wrong about stroke? You must hear so many stories from people who say, I thought she was just blank.
Yeah, there are a number of stroke mimics, and I think the biggest thing, frankly, is just human nature. And if our symptoms aren't severe, we don't fall immediately on the ground, then we sort of try to shrug them off, and we think it couldn't be happening to me. And that's usually the biggest mistake that leads to delay in arriving at the hospital. So people will say, well, I thought maybe I'd slept on my arm wrong, or, maybe I just had a headache or, migraine or something like that. And they sort of shrug their symptoms off. And I think, there's a difference in an 18-year-old versus a 78-year-old, that you need to know what your risk is for having a stroke, and it's different in everyone.
20 years ago, everything changed for stroke patients because of the discovery of the clot-busting drug. What is that?
Yeah, so that's a medicine called TPA, and it's got a big $10 terminology, tissue plasminogen activator. It's a medicine our body actually makes on its own to break up blood clots every day. We just give it in a higher dose to the patient if we want to break up a blood clot that could be causing a stroke, for instance. And it really, at the time, this is in the 1990s, it really did change the game. We had no treatment at all. I mean, the old days, if you had a stroke, you'd come in and you'd go on into rehab, and there really was no acute treatment. And I'm proud to say some of the early research in that was done at my institution at the University of Virginia. My colleague, the founder of our stroke center, Clark Haley, was one of the early clinical trial investigators, and it's been really neat to see how that's evolved over time. Now, just within the last 6 months, to see it completely shift with this whole new line of treatment.
Are we now giving patients clot-busting drugs right in the ambulance?
Well, that is sort of a holy grail idea in stroke, and it is happening. The challenge is you still need that CAT scan, because you certainly wouldn't want to give a clot-busting medicine, TPA, to a patient who's having bleeding on the brain. So you have to know, and that's where the CAT scan helps you, is it a bleeding stroke or hemorrhagic or one caused by a blockage?
Oh, you don't give the clot buster to bleeding brain?
No, you definitely wouldn't want to. It'd be essentially like giving Drano in a plumbing system where there's already a leak, and so we really need to know kind of what we're dealing with.
Can you do anything for those kinds of strokes?
Absolutely. And hemorrhagic stroke, I should underscore, it's not as prevalent as ischemic stroke, but it's certainly just as deadly and disabling. And that requires highly specialized neurosurgical care in many cases, and control of the blood pressure and intensive care and so forth. And so that's, again, another condition where highly specialized stroke centers can make an impact. If
that's not a clot, how is it that our arteries give way and allow bleeding in the brain?
If you look at just the whole population with bleeding strokes, a lot of it's trauma, falling, hitting your head, motor vehicle accidents. But outside of that, a lot of times, certainly in our older population, it's high blood pressure. The pressure gets too big for the system, and you can have a rupture of an artery and it bleeds into the brain. And then, of course, there's aneurysms. And an aneurysm essentially is a weakening of the wall of an artery, and it can be prone to rupture or bleeding.
Is there something that we eat or do that makes us more likely to have an aneurysm late in life?
We're learning more about that. There are certainly genetic conditions. In fact, the only real good screening recommendations we have are if you have 2 or more affected family members who have had ruptured aneurysms. And so there certainly is a familial genetic component to it. But we know that if you're at risk for aneurysm, your risk of bleeding from that is higher if you smoke. In some cases, maybe if your blood pressure is higher. And actually the prevalence rates are really higher in sort of late middle life and not so much the oldest of the old. So we're learning more about what causes an aneurysm to rupture, just like a volcano, right? It's going to rupture at a certain time, and then it may stabilize over time. And we're trying to understand what is it about an aneurysm that makes it more like a volcano that could erupt any minute.
You personally are doing a really neat experiment with this idea of putting specialized iPads in the ambulances or in the hands of the EMS people so that there can be even earlier contact between teams of neurologists and EMS people.
Yeah, that's a really neat idea, Sarah. The idea that there's sort of this idle time that we're having patients coming to us at the hospital, and particularly if you're in an area where that could be a large geographic area. So, for instance, at my hospital, we may have patients riding in an ambulance for 30 minutes on the way to the hospital. So why not take technology that we're all using and allow us, the physicians at the hospital, to go ahead and start evaluating the patient while they're in the ambulance? 50 to 60% of the people listening all have some sort of smartphone that they can do video conferencing with. And all we have to do is take that same technology, make it secure for private transfer of information, and all of a sudden we can go ahead and be evaluating a patient before they ever get to the hospital.
Have you tried it yet?
We're working on it. It's we're experimenting in our area, learning a lot about wireless internet connectivity, which is sort of fun, and how to be able to make this happen in a moving ambulance going over bumpy roads and in rural areas. So far, the research looks promising, and we're publishing about it and starting a protocol with some of our regional ambulance agencies.
Isn't that amazing?
It really is. And so it's just fun to be in an environment where we're still learning from ingenuity and hard work. And we still have a lot of work to do. There are even ambulances now that have CAT scans in the back of them. So sort of getting rid of this whole idea that we have to wait for patients that are having a time-sensitive, disabling disease to come to us, and why don't we just take the hospital to the patients?
Andrew, this is terrific. Thank you for sharing your insights on stroke with me today on With Good Reason.
Well, thank you, Sarah. It's a tremendous opportunity, and I appreciate you and to all the listeners out there for being aware of stroke and how we can all do our part to limit the burden.
Andrew Southerland is a physician and professor of neurology at the University of Virginia.